Oncology for the Inquisitive Mind, brought to you by Fresh Ideas and New Trials, featuring Michael and Josh. Welcome back to another episode where we dive into the lung space even more. And without further ado, because we have lots to get through today, Michael, why don't you tell us what we're talking about?
Absolutely. I like that intro, Josh. That was very slick, probably AI generated.
It wasn't, actually. I have a few original thoughts, and that's probably the one for the day.
That's one for the week. Yes. Hello, everyone. Yes, we're going to be talking about lung cancer for this episode and the next few. And so we hope you enjoy it. Today, we're going to be talking about advanced non-small cell lung cancer, following on from our last episode of early non-small cell lung cancer, in case you notice a pattern here. But specifically, we're going to talk about non-small cell lung cancer that does not have mutations, which is probably the space that hasn't changed a whole lot in the last little while, with a few variations on a theme that we'll come to. But just before we launch into our studies today, a quick background. So apparently, according to the WHO, lung cancer is the most common cancer worldwide and is responsible for the most cancer deaths, which surprised me, Josh, because I would have thought breast cancer, prostate cancer, or colon cancer would have been the highest worldwide, but I guess this shows the degree of regional variability.
That's it. Smoking and other terrible pests that a lot of the West have gotten rid of, maybe a lot of people are still exposed to. But I'd love to type that into AI. I think it should be the AI episode of what would AI say? It's like, there is not enough data for these 112 different countries.
I don't think AI ever says there's not enough data for anything. It says, if there's not enough data, I'll make up some data.
I feel that, isn't that called like fantasizing or hallucinations?
Confabulating.
Confabulations. I think there's a term in AI.
Yes, and apparently adding to the rep of lung cancer, it is responsible for more than double the next two highest cancers in terms of deaths worldwide. And the next two highest cancers in terms of death, again, interestingly, are liver cancer and colorectal cancer. There is a 2021 WHO classification of lung tumours. I'm not going to go into the whole thing because it branches off into about 15 different subtypes. So we'll talk about the ones that are probably clinically relevant for the average listener. First off is adenocarcinomas, and these are the most common kind of non-small cell lung cancer, accounting for approximately 50% of all lung cancer cases, so that's including small cell, and has multiple pathological subtypes. Acinar, lipidic, I think, is another one. If you think of non-small cell lung cancer, you're probably thinking of bog standard adenocarcinoma. The other common type is squamous cell lung cancers, which interestingly were the most frequent histological type of lung tumour in nearly all studies done prior to the mid-1980s, with the higher prevalence of smoking in those studies. These usually arise in the proximal portions of the tracheobronchial tree, and they typically present with a persistent cough, recurrent hemoptysis, or relapsing pneumonia due to obstruction. One thing that I will mention about squamous cell lung cancers, again, we won't get too bogged down with this, is they do have a higher propensity to bleed. They have a higher propensity to present with hemoptysis, as I said. You should never use bevacizumab if you have a squamous cell lung cancer, because they tried that and it ended up unfortunately killing people because they bled due to the bevacizumab. Adenocarcinomas are the main focus of most studies. They'll be the focus of the studies that we're talking about today. And they sometimes harbor sensitizing mutations. This will be the next couple of episodes that we'll be doing. But some of these include EGFR, ALK, KRAS, and MET alterations. Non-small cell lung cancers should, and routinely are these days, be assessed for PD-L1 tumour proportion score, TPS, not CPS, as is the case in breast cancer and gastric cancer, among others, but tumour proportion score, which is expressed as a percentage scale of less than 1 to 100%. The majority of cancers lie in that 1 to 49% intermediate. But that's enough beating around the bush, Josh. Let's get back to the nitty-gritty, or get down to the nitty-gritty, the nutty-grutty, and we'll start talking about some trials. I'll keep going, and I'll start talking about one of the major studies, even though it's now a good 7 years old in this space, which is Keynote 189.
Hey, Michael, it's almost as old as you.
Almost, not quite.
Also, I like the Nutty Grutty was great. This is the Nutty Grutty episode.
Nutty Grutty episode. I did steal that from another YouTuber who shall remain nameless, but yes, because I too don't have an original thought in my head. So Keynote 189 was published in 2018. And at the time, chemotherapy alone was the standard of care for untreated advanced non-small cell lung cancer without a sensitizing mutation. So at the time, things like gefitinib and erlotinib were around, I think, but we did have single-agent pembrolizumab for second-line treatment and as for monotherapy for those with a PD-L1 TPS of greater than or equal to 50%. But no one had actually tried it with chemotherapy because, as mentioned before, lung cancers with a TPS that is very high are a minority of overall cases. The rationale behind this was that immunotherapy was thought to combine with the potential immunogenic effects of cytotoxic chemo and maximize the chance of initial response and prolonged survival. I won't get too much into the details here, the nutty-grutty, as we say, because Keynote 189 is just a seminal trial. Pretty much everyone knows about it. But in brief, patients were randomized 2-to-1 to receive either pembro or placebo in combination with 4 cycles of chemotherapy. Given that we're talking about adenocarcinomas, we're talking about a combination of a platinum and pemetrexed. Notable exclusion criteria: if patients had symptomatic CNS metastases, a history of non-infectious pneumonitis, active autoimmune disease, or were receiving systemic immunosuppressive treatment, or had received some radiotherapy to the lung in the previous 6 months, they were excluded. The reason I mention that is this, at least to my mind, is one of the earlier studies that started to actually exclude people. Obviously, you had the melanoma studies beforehand, but excluded people with autoimmune conditions, which is a rare clinical entity, but one that we do occasionally come across in clinical practice. Needs a little bit of finessing, a bit of discussing with your friendly neighborhood rheumatologist as to how high risk it is for these patients to be on immunotherapy if they have raging lupus. The primary endpoints were overall and progressive-free survival. It's good to see overall survival being a primary endpoint. Secondary endpoints were response rate, duration of response, and safety. The demographics were well balanced. Slightly higher proportion of patients in the pembro group had an ECOG performance status of 0. The majority of patients were current or former smokers, and there were similar rates of brain metastases, that's stable or treated brain metastases, in the two groups. So in terms of the initial results that we got, the median overall survival was not reached in the combination arm versus 11 months in the control arm, hazard ratio of 0.49, which was great. And the overall survival benefit was seen in all subgroups. And it was approximately proportional to the degree of PD-L1 expression. A lot of pathology tests will group PD-L1 TPS into basically 3 groups, which is less than 1%, 1 to 49%, and greater than 50%. Some of them won't even give you an accurate number. But it's important to remember that TPS is a continuum. So in general, obviously it's not always the case, but a patient with a PD-L1 TPS of 3% is going to have a lower likelihood of a good response than a TPS of 30%, even though they both sit in that 1 to 49% range. Similar story with the progression-free survival, which was approximately double, hazard ratio of 0.52, and again, consistent across all subgroups. In terms of the final results, which were published a year later in 2019, 84 patients in the placebo arm crossed over to the pembrolizumab in subsequent therapy from the placebo arm. Despite this, the hazard ratio for overall survival was 0.56, with a median overall survival of 22 versus 10.6 months in the pembro and placebo arms, respectively. So better, but still not great. The 2-year overall survival was 45.7 compared to 27.3%, which again, I think highlights more than anything how abysmal chemotherapy is in the management of advanced lung cancer. And in terms of safety, I mean, this is, as I said, one of the earlier immunotherapy studies, although maybe it just seems like that to me because this is around the time that Josh and I were starting to actually take an interest in this sort of thing. The safety, the toxicities were very much what you'd expect for a combination of chemo-IO, stuff that we really do have a lot of experience with. So the conclusion to take from Keynote 189, it's a standard of care, or the standard of care, I should say, for advanced non-squamous, non-small cell lung cancer, because remember this was adeno, with a PD-L1 of 1 to 49%. I will make a quick note on the squamous question because I know that's something that was excluded from this study. This was examined in the very similar Keynote 407, which confirmed the superiority of combination pembro versus chemo, which was carboplatin plus paclitaxel as opposed to pemetrexed, over chemotherapy alone with a hazard ratio of 0.71. Again, very poor long-term overall survival with a 5-year overall survival in the chemo-IO group of 18%. So yes, this is better. And this is probably something that we're going to say repeatedly, Josh, over the next few episodes. Better, but still a lot of room for improvement, which probably is as good a segue as we're going to get into your study, which is a Checkmate.
Yeah, it probably wasn't Checkmate in this particular scenario, Michael, but that's why we gave you the study first, the nutty-grutty study. So Checkmate 9LA was a immunotherapy-based trial looking at ipilimumab plus nivolumab. You're probably like, oh, I know those drugs. They're used in melanoma. And you would be absolutely right. But this time, they're used in lung cancer with some chemotherapy. And this was a large international randomized open label phase 3 study. The background, Michael's gone through it, so I'm going to absolutely skip everything I wrote here. But this...
Just completely torpedoing your work. Apologies. This is why we don't communicate.
Yeah, we do, just maybe not well. So the study was stage 4 non-small cell lung cancer, similar profile to Michael's patients, and they were stratified according to PD-L1 of less than 1% and greater than 1%, randomized to either nivolumab plus ipilimumab. And they sort of had a similar thing where that was given plus of chemotherapy for 2 cycles versus chemotherapy alone. And look, the standard is going to be 4 cycles of IPI. They're not going to continue that long term. And it was continued until disease progression or 2 years for immunotherapy. Primary endpoint was overall survival and secondary endpoint was progression-free objective response rate, etc. So 365 patients randomized, median follow-up time was 75 months, so pretty nice follow-up time. And all patients at time of this reporting had discontinued study treatment. I think it's a 6-year follow-up. So median duration of treatment for this particular cohort was 6.1 months up to a maximum of 24.4 months. Someone obviously skipped the memo of finishing at 2 years and they went just over 2 years, and 2.5 months up to 72 months in the chemotherapy alone arm. So there is someone who either didn't have metastatic disease or just responded indefinitely.
Didn't even have lung cancer.
Didn't have a lung.
Wasn't even a person. Apologies if that person is listening.
Good job. Please come on the show. Actually, we'd love to talk to you about your journey. I hate the word journey in cancer, your experience. So going back to actually important statistics. So alive at the 6-year mark was 33% versus 25% in the chemotherapy alone. And the median duration of response was 23 months in the immunotherapy versus 8.7 months in the chemotherapy. Subsequent therapies, immunotherapy in about a third of patients who already had immunotherapy, and 50% in the chemotherapy arm, 8 and 37% had subsequent immunotherapy, and 36% and 28% had subsequent chemotherapy. So people who had good response on chemo switched to immunotherapy. People who had immunotherapy weren't re-challenged overall. So efficacy data, the overall survival was hazard ratio of 0.74, which was statistically significant. And the 6-year OS was 16% versus 10%. So not great, Michael. And where it gets really interesting, and I'd love to get your take on this, is the PD-L1 status, because I thought I read this wrong and I've gone back and looked at it again. But the PD-L1 status of less than 1 versus greater than 1 showed some really interesting results. So the OS, like overall OS, at the multi-year mark was 16 versus 10%. At the 3-year mark was 27 versus 19%. But then if you break it down to the less than 1 and greater than 1, the less than 1 seemed to have a response rate of 20% versus 7% for PDL less than 1. And then PDL greater than 1 was 15% versus 10%. So my question here is the biology of these tumors who have PDL1 expression, are they A, better, or B, because they subsequently went on to immunotherapy, that overall survival trend actually changed the paradigm of these patients? It's an interesting question.
Yeah, it is. You've always got to say, these are not comparative graphs, they're subgroup analyses, pinch of salt, all that sort of stuff. It is interesting. It does raise interesting questions about the biology because it doesn't really make sense. And you do have occasionally these instances where the placebo arm, for whatever reason, or the control arm in this case, overperforms compared to baseline. Interestingly, though, if we sort of do a dirty cross-trial comparison between this and Keynote 189, The control arm is actually significantly worse in the PD-L1 less than 1%. I think the average overall survival for the control arm was about 11 months in Keynote 189. I should know that better because I just spoke about it about 5 minutes ago. But it's 9.8 months here in the PD-L1 less than 1%. So it might be that it's less, or it's partially, this is going to be one of those messy multifactorial things, but it's going to be partially due to the fact that the chemo arm is actually not doing as well as one would expect. There's so many things that could have happened though.
That's it. One other little side point before we finish is that I'm like, oh, this is interesting. I'd love to understand because Michael's trial is the standard of care for this cohort of patients. But why wouldn't we use this combination? You still have efficacy endpoints, and it actually comes down to toxicity. But the issue is there's a lot more tox in the dual immunotherapy agents as an overall rule. And there was a Japanese study called the JCOG 2007, which looked at this. And they terminated the study early because 7% of the patients in the ipi-nivo arm died, which is a lot for a trial. 1 to 2% is not great having someone die. And toxicity was about 20% more, give or take. And so that's probably the reason that people will avoid it if the efficacy is not better.
Absolutely. And I think you did say that the IPI was discontinued. I think that they actually kept it going because it's 1 milligram per kilogram every 6 weeks. Lower dose than melanoma, but it does mean that you keep it going, which obviously portends you to more of that nasty IPI tox. Try saying that 5 times fast, nasty IPI tox. So it's just important because, as we know with melanoma, the IPI-nivo combination usually is pretty well tolerated basically until it isn't. And that's because you stop after those 4 cycles, but that is also at the higher dose. The longer you're on immunotherapy as a general rule, the more likely you are to have immune-mediated side effects. So the only time I've seen this regimen actually used in clinical practice is number 1 with squamous cell cancers. That's the main thing because there is a documented benefit for squamous cell cancers, and that's a subgroup here as well, I can see. The other thing is for patients that are obviously very fit.
Yeah. And look, the squamous one, there is a numerical benefit, but I don't know if there is that statistical benefit again, at least in the study I looked up.
Yeah, I think it's still a niche. It is approved. You can do it. I think you do have to be very careful about who you select if you want to use Checkmate 9LA.
There we go. Well, Michael, you took the breath out of my presentation.
The wind out of your sails. I'm a wind stealer.
I'm a windless nutty gruddy today. What's next?
So we're continuing with the advanced non-small cell lung cancer theme. Next week, we'll be looking at a couple of very interesting trials with respect to mutant non-small cell lung cancer. It's Magneto against Professor X. It's Deadpool versus Wolverine. It's EGFR and ALK, when we'll be talking about 2 very interesting studies, Mariposa and Crown. So we hope you'll join us next week for more Nutty Grutty.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.